way. Our moderator tonight is a lifelong Prince William County resident, Rebecca Barnes. Rebecca is the publisher of Prince William Living, which you haven't seen, you should. She's been an entrepreneur for 17 years, starting and running several award-winning companies here in Prince William County. In addition, Rebecca served for 12 years on the board of the Chamber of Commerce, was its youngest female chairman. She was a founding task force member. First chairman, and graduated from the first class of leadership Prince William. Ms. Barnes was, prior to her current work with Prince William Living, was president and CEO of Pac Mail, president and CEO of AMPM, which is a branch of American Red Ball Van Lines. She also held the position of chief operating officer for Bargain Boxes Moving and Storage. In her spare time, if you believe that, she has spare time, she serves with the Occoquan Woodbridge Lorton Volunteer Fire Department and lives in Manassas with her husband and 2 sons. Rebecca Barnes, for tonight's program.
Thank you very much. Okay, so let me just, you do have the bios, hopefully, of our speakers, and I don't want to take too much of our time, so I'm going to kind of do a slightly abbreviated version. I hope everybody is okay with that. Our first speaker is Robin Adams. Robin has 19 years experience in healthcare strategy and business development. She started her career at Booz Allen Hamilton and was recruited by Children's National Medical Center in Washington, D.C. To direct the ambulatory development in its regional outpatient centers. In collaboration with Children's Executive Team, she led the strategic plan to develop and execute the ambulatory strategy to drive pediatric subspecialty access in communities throughout Maryland, Virginia, and D.C. After 8 years at Children's National, Ms. Adams was subsequently recruited by Inova Health Systems. As the Chief Growth Officer for Inova Eastern Region, Ms. Adams was responsible for the development of business strategies to enhance clinical service lines, the recruitment of key physicians, and the improvement of patient experience at Inova Alexandria, and Inova Mount Vernon. Most recently, Ms. Adams has assumed the position of Director of Marketing and Development at Sentara Hospital. During her 2-year tenure with Sentara, she's been responsible for leading growth, clinical service line development, and brand awareness. She received her BS in Nutritional Finance at Cornell University and an MS in Genetics from Georgetown University and an MBA from Virginia Polytechnic University. She and her husband Mark live in Alexandria.
Next we have Dr. Vic Coate, MD. Dr. Coate currently serves with the Medical Director for the Department of Behavioral Medicine at Novant, the professional position he has held since 1993. His duties in Novant Hospital include the development and review of department policy, procedures for patient care, development of treatment protocols, and hospital staff development. Concurrently, Doctor is also an associate clinical professor at the Department of Psychiatry and Behavioral Science at George Washington University. Wow. Did you all read through this? Because I know I read it, but this is going to take a little bit.
You could wait until he's going to talk.
Yeah, there we could see that. I could read it, right? Dr. Coate received his medical education at Bangalore Medical College in Bangalore, India, and completed his residency in the Department of Psychiatry, Medical College of Wisconsin, affiliated hospitals in Milwaukee, Wisconsin, with additional training at the National Institute of Mental Health. He's currently licensed in Virginia, Wisconsin, and Maryland. That's quite a commute to Wisconsin, I'm sure. And has published several articles and received numerous honors and awards, including voted as one of the top doctors in psychiatry in the Washington metropolitan area by a jury of his peers, as well as magazines like Northern Virginia Magazine's Top Doctor in 2010, 2012, 2013, and 2014. Next we have Rita Romano. She is a licensed clinical social worker, who's been providing community behavioral health services in Virginia for the past 35 years. She currently holds the position of Emergency Services Division Manager for Prince William County Community Services in Prince William County, Virginia. She has a master's degree in developmental clinical psychology from Antioch University and a master's degree in social work from Catholic University of America. She also maintains a small private psychotherapy practice in Woodbridge at Woodbridge Psychology Associates. Ms. Romano has nurtured a keen interest in the involuntary commitment laws for many years. She served on the commitment task force that supplied the information and recommendations to the Commission on Mental Health Law Reform that was commissioned by Chief Justice Leroy Hassel. She's also served 2 terms as the chair for the Board of Emergency Services Council of the Virginia Associated Community Services Board. Stacy York has 24 years of behavioral health care, clinical, and community relations experience, including facility senior management and corporate level positions. She specializes in fields of community needs assessment and state and federal public-private sector partnerships, most recently as a creator of Freedom Care Program, an inpatient specialty program for active duty service members. Ms. York has held positions with large companies including Universal Health Services, Ascend Health, Psychiatric Solutions, and Providence Healthcare. She's also a veteran of the United States Air Force. Ms. York earned her degree in liberal arts from St. Leo College. Okay, so now that we have introduced you to our speakers, we're going to go ahead and begin the process and let each person take 10 minutes. And Jim is your timekeeper, and there will be no caning. I don't do that. So you're fine. Just pay close attention when he gets to the end. And we're going to go ahead and start with Robin. Thank you.
Good evening. Thank you for having me. I actually want to thank Jack. Jack reached out to me about a month ago, and we had just a lovely conversation and we were about 2 degrees of separation separated from Ithaca, New York. And so I said, absolutely, I know nothing about the Committee of 100, but it reminds me a lot about the dialogue I'd have around my family dinner table, which, again, I appreciate speaking with Mike and duties all this afternoon or this evening. So without further ado, I wanted to give you an update. Before I get started, how many of you have heard of Centera Healthcare? Yay! How have you heard about us?
It's in our neighborhood.
It's in your neighborhood. And actually, Connie, I want to thank you. You just are a wonderful spokesperson for us. So that's good to hear. We are a company, I'm sorry, next slide. Actually, let me just give you an update. Just quickly who we are first, because a lot of folks don't know who we are in the Northern Virginia market. I wanted to tell you a little bit about our merger, and then most importantly, get to what we're here for in terms of talking about mental health and what we do, and then more importantly, what we're doing in collaboration with the community outreach we're doing through our community health needs assessment. So next slide, please. Very quickly, we do have a 125-year history. We're based in Hampton Roads. However, we are new to Northern Virginia. I say new. A merger took place with formerly Potomac Hospital in December of 2009, and it has been a labor of love for the last 4 years. I've been there too, working on the processes, the foundations, the quality of the patient experience, recruitment of physicians over the last few years. And as you can see, we are statewide, and we're very excited to be in Northern Virginia because we do see that there's great opportunity to continue to grow and improve the health of the communities we serve. Just very quickly, some highlights. We are based in Hampton Roads. We're in the Blue Ridge and now in Northern Virginia, and we're in North Carolina as well. And my former boss, Megan Perry, who some of you may know, actually is heading up mergers and acquisitions, so who knows where we'll be. We do have 650 providers, whether they are advanced practitioners or licensed physicians. We do have a health plan. So we have about 450,000 members in the Hampton Roads market, Blue Ridge market as well. We do have a behavioral health service line across the system and about 70 to 80 behavioral health beds at our Hampton Roads based as well as our Blue Ridge hospitals. Next slide. So who are we? We're here to improve health every day. It's a really simple mission, and everybody in our organization is a part of that. We have 25,000 members of the team, and we all take a part in improving health every day. It's a real simple, basic mission statement, and we live it every day. We want to be the healthcare of choice in this market. We are high achievers. We want to be top 10% in everything we do, nationally. Next slide. So how many of you are familiar with Potomac Hospital? Okay, it was founded in 1972. It was one of the last grassroots hospitals in the state of Virginia. And in December of 2009, we merged, Centera Healthcare merged with the hospital. And as part of that, Centera Healthcare invested $92 million into the community because we felt that there was that much opportunity to continue to grow and build a foundation. So today we have what is called the Potomac Health Foundation, which is part of that $92 million, which you're going to hear a lot of projects as related to mental health that are funded by that foundation. We also, as part of the merger, brought in EMR, electronic medical records, the future of health. We all know digital is in all other industries. We felt we needed to bring that to healthcare locally. We were an early adopter in digital in Hampton Roads through an electronic medical record. Why is that important? Safety. Next slide, please. So today, what do we have today? We have a 24/7, 365 program. I will call them behavioral health liaisons in our emergency department, headed by Ellen Hayes. All of them are master's prepared clinicians, and they are there 24/7. After a patient presents to our emergency department, they are stabilized medically cleared, and then they are counseled and go through a very stringent health screening or medical screening for their mental health. And then they're rated. Are they low risk, moderate, high risk? And then they are triaged appropriately. Once the patients are medically cleared, the voluntary patients are transferred. So our program is stabilization, medically clear, stabilize the patient, make sure behaviorally they are stable, and we do transfer them, thank you, to Novant primarily. So Betsy Riley's team. After Novant, if there are no beds, Inova, Mount Vernon or Fairfax, or Loudoun, but primarily Fairfax and Mount Vernon, and then Dominion Health or Snowden. Typically, in speaking to our behavioral specialists, we are able to place those patients within 1 to 3 hours. Then for the involuntary, that's when we work very closely with Rita Moreno, as well as Doris Miller from the Community Services.
She was close.
Did I say something wrong? I said Moreno. It's Romano. Romano. Sorry, Rita. I told myself I wasn't going to do that, and I did. Romano. Next slide, please. For outpatients, again, most of the patients who do present to our emergency department require just stabilization, and they're in acute crisis. So what we're able to do is we make the call to the community services if necessary, and or we are able to, we have a list of about 25 to 30 resources, psychiatrists, counselors, psychologists, licensed social workers who will see those patients within 2 to 3 days after they've been stabilized. And as you can see, we've got about 25, as I said, 25 licensed professionals who we use as our strong key partners in the community. Next slide, please. So I talked a little bit about the Potomac Health Foundation, and I just want to point out Stephen Bacci is here, the Executive Director of Potomac Health Foundation, and I made sure that anything I say was appropriate, so, or not. But again, just to remind you, when Centera came to Prince William, we invested $92 million into the Health Foundation. Why? Because we felt that it was important to invest in the communities we serve. So it is, I just want to make sure folks know, Potomac Health Foundation is a private independent organization devoted to wellness. And they have been terrific partners in looking at community need and helping to fund grants that are brought to them in the area of mental health. Next slide, please. So their mission statement, very quickly, improve the health of the community by increasing access to health care, in this case mental health care, for underserved and reducing the prevalence of preventable disease. And they do it innovatively. Next slide, please. What I'm going to do next is I wanted to share with you, we have about 12 programs that, and actually just to let you know, 2 minutes left, we have a number of 12 programs that have been funded through the Potomac Health Foundation that are devoted to mental health. Very quickly, the Phoenix Family Counseling Program serves about 260 folks, supports families who present with symptoms of trauma, depression, anxiety. Again, I'm going to go through these very quickly. I do have a piece out there that have all of them listed if you'd like that for your reference. Next slide, please. Centerra, Northern Virginia, we have our Family Health Connection van, and Evelyn Marr, who works with me, goes out to see the patients in her van. She sees quite a few of the mental health patients, and as a nurse practitioner, does just the medication management for those patients, and serving almost 1,500 patients in an outpatient setting. Next slide. Youth for Tomorrow. Anybody here? Wonderful organization in Bristow. We've got 2 programs that are funded. This one serves about 135 kids between the ages of 10 and 21. Kids in crisis, very important. Next slide, please. And then lastly, the next one is the assessment of children aged 3 through 18, screening the mental health of the kids who present with aggression, anger, and or threats to self or others. Next slide, please. And then very quickly, the Change in Action. This is really a family program. So we talked about peds, adolescents. Now this addresses the whole family dynamic. So again, serving about 175 patients and families, really becoming aware of anger management, aggressive behavior. 20 seconds left. Next slide, please. Is there a need for further mental health in this community collectively? Absolutely, but we need to do it together. We actually just finished a community health needs assessment with about 20 organizations across the Prince William community, Area on Aging, school system, Harvest Life Changers Church, a whole host of others. We came up with what we believe our agenda is for community health going forward, and we meet quarterly to check in. How are we doing? We agree to these things. How are we doing in the area of mental health? So we're going to be working with the Greater Prince William, Dr. Ancher and Karen Fuji, as well as faith-based ministries. We feel that we need to work through the congregations, building trust in an outpatient setting, Community Services Board, so working with Rita and her team. We supported some local COPN efforts to increase bed complement. And pipeline. Do we have enough psychiatrists? Do we have enough LPNs and NPs? We feel that we need to partner with the colleges, the universities, to develop a curriculum to fuel and educate our future. People are not getting into behavioral health like they used to. So we are seeing a representation of that with a dearth of providers. We need a pipeline and we need a workforce. Some of the other creative things we're thinking about, and we'll probably put in an application to the Potomac Health Foundation, mobile health crisis. We talk about a mobile van. Is there a need? Is there an opportunity to partner, get vans out there, and get us to the people? So again, how do we, the community, with the hospital and the foundation, partner to make a difference? And then lastly, we have, as part of Centerra, a telemedicine program. Telepsych is actually really catching on. Anybody have an iPhone? Anybody ever use Skype? Or might be something that we consider. Might be an opportunity in partnership with somebody in the community, as well as our health foundation, to fund something creative and innovative, whether it's through our school system or it could be home-based. So we have a lot to do, and when I say we, I mean the community in collaboration with us as one of the many providers of mental health services. So happy to answer any questions during the panel.
All right, next we're going to ask Dr. Vitcote to come up and to give, okay, or do we need to, are we staying in order, or are we?
Yeah, but he doesn't, you don't have any slides, man.
No, we'll come, you good? Come on down.
Thank you, Rebecca. Can you guys hear me? Yeah. Okay. Thank you so much for inviting me. I guess the first answer to the question is, this question is 23 years too late, but it's better late than never. I want to let you know that I was a last-minute stand-in. I feel like I'm an understudy in a play. And have to come in. Now let me talk a little bit about, first myself briefly. I've been a physician for 31 years and almost 29 in psychiatry. And I came to Prince William in 1991 when they were, I came to Prince William in 1991 when there were hardly any psychiatrists. I work for a system called Novant Health System, and much like Centera, we are a 14-chain hospital with a new hospital opening in just a few weeks from now in Haymarket, and we have about $4 billion in revenue, and we're across 4 states. And the interesting thing about Prince William and Centera is both had a merger in 2009. Potomac had a merger with, of course, Centera, and Prince William Health System had a merger with Novant Health, which is a 14-chain hospital across 4 states. Now, the one thing about Prince William, it's going to be 50 years old, Prince William Medical Center. And the one thing about Prince William is that we had an unwavering commitment to psychiatry. You know, there are a lot of people who come and tell you they're going to start a program, they're doing this and that. But in 1982, many of you may know the late Dr. Woodside started a 10-bed unit in the main hospital, and now we're a 32-bed unit, expanding to 8 more beds of detox. In 1999, we had only 1 psychiatrist, and now we have 12 psychiatrists, 6 inpatient and 6 outpatient. And essentially, these doctors, along with nurse practitioners and mid-levels, as we call them, nurse practitioners and physician's assistants, are really helping the community. I think the huge gap in Prince William, I believe, is in outpatient care. Now, if you go back to, let's just step away a moment and look at healthcare in general. The biggest problem in healthcare today, I mean, many people give you lots of information and conflicting data. You can really summarize it into 3 problems. There's overuse, underuse, and misuse. Clearly, in Prince William, I think I would say there is underuse, there's a bit of overuse in hospitals, length of stay, and there's also misuse when people are, you know, for example, if you just have chest pain, you don't need a cardiac cath and you don't need a bypass, and you're taken to bypass. Billions of dollars have been spent on bypass. And I think it's important to understand that when we begin to fix these problems, healthcare will improve. And the biggest problem in healthcare is it's unsustainable. You know, I know it's a political term, but we are something like 17% of GDP, $2.7 trillion we're spending, and it's simply unsustainable. In the past, 70% was inpatient. I remember even when I was training, there were people who were tired, they would come into the ER, and the doctors would admit in 2 to 3 days. Now, you're lucky if you have a gunshot wound to the head, you may be discharged the same day when you come to the ER. So it just shows you that's how things have changed. And it shows you 70% was inpatient, 30% was outpatient. Now the system is turned, 70% is outpatient and 30% is inpatient. So, and you've heard of other speakers as well. For example, the Institute of Healthcare talks about the issue of access, inequity, waste, and redundancy. And these are basically the healthcare problems. So there is, nationally, there's what's called a triple aim. Triple aim is really to put it simply, it's quality, service, and value. And to put it a little more complicated, it really talks about enhancing the patient experience, population control, that is all of us. It's not just a episode of care where someone comes in and you have to see a specialist. It's sort of a one-stop shop, and so that everyone is connected. And the last, but the most important aspect of the care is reducing the per capita cost. There is not enough dollars to treat people. For example, again, this may be a little political, but if our state doesn't expand Medicaid, even though I am not, I don't want to go into the politics of it, it will cost the state $1 billion or more. And I think this community is going to cost us 40,000 individuals. So you can imagine, even in Prince William County, there's underinsured and uninsured people. So you are looking at trying to help them. So you have this AAA, and Novant, we have a system called the PODS, or the Patient-Oriented Delivery System. And it doesn't mean that everyone has to be in the same health plan. It means that we get people, put them in a pod, follow them, and really tackle three major things: diabetes, obesity, and hypertension, to try to bring down the costs. Now, coming specifically to the question of mental health, we've had unwavering commitment both by Prince William Health System 4 years ago, and also Novant Health, which is now, in fact, we are the third largest admitter to the hospital. And even in our old system, we've seen admission rates go down. In the last 3 years, we've had 256 less admissions, and that is the future. People are being cared for at home. There's the patient-oriented medical home. There is what's known as electronic records. Excuse me. She spoke about the electronic EMR, electronic health records, and Novant just last year committed $600 million to electronically, shall we say, creating a universal electronic health record. Let's say the company had $1.3 billion in cash, $600 million was spent to help these, to centralize records, to make people in the community sign up and look at what happens to the hospital. We're the only hospital for the last 2 years that has complied with 100% of sending information to providers when patient leaves the hospital. Of the 9 hospitals in the Northern Virginia area, we're the only hospital that got money back from value-based purchasing from Medicare. So what Medicare does now is they hold 1% of your bill, so to speak, or revenues that you bill them, and then if you meet the quality metrics, they return that 1%. So it's not even like you're getting the 1%, it's withheld and returned. So this is the way to go. And just imagine a health system that has employed 12 doctors and is working on expanding inpatient, outpatient mental health treatment. Because after respiratory illness, the most common illness in the country is mental illness, whether it be a simple breakup in a relationship, whether it be panic attacks, whether it's depression. For example, depression beats cardiovascular disease as the #1 disability in the country and in the world, according to WHO, and of course the CDC. So it shows you that we are committed and continue to be committed. And the way of the future is not, bricks and mortar, but the way of the future is really cords and Ethernets and trying to connect people and help them, get care as they can. For example, you've seen machines where, if anyone saw ABC News a couple of weeks ago, you saw this, basically, with your iPhone, you can get your EKG reading done. If you have a little chip, it constantly tells you your sugar, you can monitor your sugar. These are the way things are changing. For example, our new hospital, rather than hiring 24 new staff, we have telemedicine already working. If a patient comes to the ED, we have video visits or electronic visits or telemedicine where we can talk to them and make appropriate, shall we say, disposition. I have 1 minute left. I was just going to tell you that we really have to work towards this, because all of you know as patients, even if I have gone to physicians, I've had my kids seen by doctors, and people make mistakes. In fact, in psychiatry, in mental health, the saddest thing is there's a huge gap between care that is recommended and care that is rendered. And you've all experienced this even in healthcare. You go to somebody and they just say it's strep throat, and it turns out to be something more serious. And I really believe that the Novant's mission is sort of similar to Centara's, except it says improving the health of the patient in the community, one patient at a time. And its vision is giving remarkable care in every dimension, every time. And we've been there for maybe 32 years. We keep giving the care, and we continue to do so with expansion. Thank you so much for your attention.
Thank you, Doctor. Next, I'd like to introduce Rita Romano.
Okay, well, I've got a slide presentation here, but I'm going to try to go through the slides pretty quickly.
Let me get them set up for you. Hold on just a second.
Okay, all right. The last time that I presented here, it was a few years ago. It was after the Virginia Tech tragedy, and the theme was, what did we learn from Virginia Tech? And, you know, we went through this long discussion, and at the end of the evening, someone, Harry, who I don't see him here tonight, said, what is mental illness anyway? And so I thought I would start out with talking about what mental illness is.
Sorry.
So it's not that.
She wanted a clicker and we don't have one.
Yeah, I'd love to have a clicker, because I'm going to have to skip some of these. I'm definitely afraid I'm going to run out of time. I feel so much pressure up here.
Go right ahead.
I know, thank God.
Good job.
Timekeepers.
Thank God. Yeah, that's right.
I do not know why this is not opening. Hold on a second.
Wrong one.
That was the one that was scrolled down. I knew I shouldn't have given him a glass of wine.
That's Centera still.
Gotta go down first.
Right there.
This is it, right?
Yeah, that looks like it.
That's it.
All right.
Go for it.
Go to the next slide. All right, so what is mental illness, and what do you think mental illness is? Excellent. Okay, this is the National Alliance for Mentally Ill. Mental illness is a medical condition that disrupts a person's thinking, feeling, mood, ability to relate to others, and daily functioning. Just as diabetes is a disorder of the pancreas, mental illnesses are medical conditions that often result in a diminished capacity for coping with the ordinary demands of life. Next slide. Next slide. I want to keep it here. Yes, this is good. Go back one. Because this is the man who helped write the DSM-4. Now that's the diagnostic manual that all of us look to when we diagnose an individual. So he said, there's no definition of a mental disorder. It's bullshit. I mean, you just can't define it. He says these concepts are virtually impossible to define precisely with bright lines at the boundaries. Next slide. So what do you envision when you think of a person with mental illness? Do you think of James Holmes, who was the individual who shot a number of people at a movie theater in Colorado? Do you think of Cho, our own tragedy here at Virginia Tech, 32 victims, students? Do you think of the homeless? What do you envision? Definitely, we have a problem with our homeless having a high degree of mental illness. Some of the individuals who are mentally ill have committed violent crimes, but by and large, as a group, they are no more dangerous than the general population. Okay, go to the next one. What about Sir Isaac Newton? He possibly had schizophrenia or autism. He wrote a lot of delusional letters and had mood swings. Next slide. Abe Lincoln, severe depression. Next slide. Elton John, bulimia and substance abuse. Next slide. Catherine Zeta-Jones, bipolar disorder. Barbara Streisand, social phobia. For 20 years, she couldn't perform. David Beckham, obsessive compulsive disorder. Brooke Shields, postpartum depression. John Nash, he was the character, real life character in A Beautiful Mind. He had schizophrenia. He went on to earn the Nobel Memorial Prize in economics. So the reality is, life is difficult. The cartoon says, everybody else seems so happy and normal. I wish I wasn't the only person with mental health issues. And the reality is, we all experience mental health issues from time to time. Life is difficult, and a certain level of anxiety and depression, I think, comes along with being human. Next slide. So, 45.6 million Americans suffer from any mental illness in 2011, and only 38.2% of those people received any sort of mental health services. Next slide. The reasons that people don't seek care, the top one at the top is cost. There's two others down there that relate to insurance is not covering enough. And you can't quite see it, but a lot of that has to do with stigma. Next slide. So in 2012, there were an estimated 9.6 million adults age 18 or older in the United States with serious mental illness in the past. Now, there's a real difference between a serious mental illness and just sort of your run-of-the-mill mental illness. And sometimes it's hard to distinguish the two, exactly where that line is, but a person with a serious mental illness has some serious functional impairments. So they're not able to hold down a job, they're not able to sustain going to school, sometimes their social relations really suffer, they're homeless perhaps, or on the verge of losing their housing, that kind of a situation. They tend to have schizophrenia as a disorder, or manic depressive illness, or major depression. Next slide. Dorothea Dix is a person who sort of started the whole development of establishing separate facilities. She went in to teach religious education classes to poorhouses and jails, and guess who she found there? A lot of the mentally ill, and in horrible situations. So she lobbied for facilities, separate facilities, 120 of them by the time she died. Next slide. This is a very interesting slide because it shows levels of institutionalization. So you've got kind of a combined one at the top there. The red line is psychiatric beds. Now these are public psychiatric beds, and guess what the dotted blue line is at the bottom? Does anybody can tell? No? Those are our jails. That's the number of people in jails. Okay, and at the line where they converge is about 1970. So as we closed a lot of the state beds, we started seeing a lot of people coming into the prison system, the jail system. Now something else happened in 1970 as well. What was that? War on drugs. That's also, I think, been some reason for that large increase. But next slide, please. We are seeing a lot of people. This is basically showing the cuts that have been made for mental health in the states. Next slide. So according to a 2012 mental illness in jail report, 1 in 4 inmates in local and regional jails in Virginia was known or suspected to be mentally ill. So, and 56% of those people were suspected to have serious mental illness. That's a lot. We were just talking about that today at the Divert meeting. Next slide. So our Prince William County CSB budget, about 37 million. General funds is 18 million. That's, again, Prince William County taxpayers. Just for comparison, the Fairfax Falls Church, their budget is about 4 times ours, and the general fund is about 6 times ours, just to kind of give you, some reference points. Next slide. So in Northern Virginia, we've got 6 private hospitals that we use for inpatient psychiatric treatment, yet 25% of the time we're going outside of Northern Virginia for a TDO bed. A TDO bed is when a person is, because of their mental illness, a real danger to themselves or other people. or they are lacking, they're suffering so much from their symptoms that they're not able to care for themselves. So unfortunately, we are going out of our community a lot, and as far away as Williamsburg at times. So again, we want to make sure that, again, with the Deeds case, we don't want that to repeat here. Next slide. One of the things we also have developed are crisis stabilization units. This is a crisis stabilization unit. It is in a residential setting. It's a more normalized living environment for a person than to go into a hospital. People don't see themselves so much as being sick, and they receive very good care. They're very personalized care there. We've got a total of 4 facilities in our region, a total of 30 beds. Next slide. Prince William County Community Services. Again, we offer a wide variety of services. I do have some pamphlets here tonight, but in terms of focusing on mental health issues, our outpatient mental health services have really, we had so many people coming in that a few years ago we had to make the decision to only serve the seriously mentally ill. We had so many people on our waiting list, and we just couldn't justify that. All in our mental health services now, apart from emergency services and some services that we have for youth, we're focusing on the seriously mentally ill. Next slide, please. So unfortunately, we have a lot of waiting lists for people. We still have waiting lists. We've got about 85 waiting for case management services, 42 waiting for psychosocial rehabilitation. That's where a person can go in, have a, kind of like a day program, kind of focuses on vocational rehabilitation. 64 currently waiting for community-based management, mental health skill building, intensive community treatment. Some of these people have been waiting for years. Next slide.
And those are all in the county, right? Prince William County?
Yes. Next slide. Go skip that one. Next slide. Great Deeds was attacked by his son. They've got a proposal of $38.3 million that Governor McDonald has made in mental health spending. Next slide. The Affordable Care Act. It's the most significant reform to mental health coverage in our nation's history. Mental health and substance abuse treatment is one of the 10 essential health benefits that insurance plans must have. Medicaid expansion is really critical for Virginia. Right now, there are a lot of people that are not eligible for Medicaid. Virginia ranks 7th per capita in personal income and is 47th per capita in Medicaid spending. So, next slide. So, mental health matters. Take care of yours. So, I hope that answered the question.
Yeah, you would have come with the physical makeup.
Now we're going to ask Stacy York to come up.
Thank you so much for having me. I was just curious with the timekeeper if we got 3 timeouts per quarter or we had to go straight through. My name is Stacy York, as they've said, and I am with U.S. Health Vest. We're a psychiatric hospital corporation, and I'm representing a proposed hospital called Behavioral Hospital at Woodbridge. Some of you may not be familiar with the CON process, so I just wanted to explain that. That's called Certificate of Need, and in order to open up a psychiatric hospital, you have to put in an application to the state and go through a very long, which could be 1 to 2 year process, which is very complicated, very legal, and have to prove the need for the beds and get permission from the state, basically health department, and the commissioner of the health department makes the final decision, and there's several stages in the process. So we are in that process, we're in the final stages, and so I just wanted to introduce our project to those of you in the room and the needs that we've uncovered in the area here in Prince William County. Behavioral Hospital at Woodbridge, next slide. Behavioral Hospital at Woodbridge is the only, and I'm stressing only, proposed inpatient project that is designed and able to meet the behavioral health care needs of the residents of Prince William County. And I look forward to giving you some additional information to back up my use of the word only. Next slide. A description of the project is that it's going to be a 75-bed psychiatric hospital located at 3321 Noble Pond Way. That's over by the fire department off of Prince William Parkway. We're going to provide inpatient psychiatric and substance abuse treatment to patients of all ages, and we're going to have specialized services. And one of the things that our management team is known for in the industry is our development of not just specialized services, but very specialized services, like a separate senior program with programs just designed for seniors, a special military program that treats combat PTSD with evidence-based protocols approved by the DoD and the VA, and trained staff in the uniqueness of the military mission to provide the care on a separate unit. So when I say specialized, I'm meaning very specialized. We're also going to have a psychiatric intensive care unit, which is not that different than an intensive care unit in a medical surgical hospital in that it's separate and it treats the most acute patients. What's really nice about having a psychiatric care unit that is separate, it does take the TDOs that Rita mentioned, the patients on temporary detention orders, but when you keep them separate rather than admitting people who are very acute on a unit that mixes all the patients together and has general treatment, you don't have to worry about how they mix with the other higher functioning patients. And sometimes the behaviors of the psychosis and things like that the seriously mentally ill patients experience can scare the other patients or make them uncomfortable. And sometimes they will even sign out against medical advice, okay? So being able to have a unit that just specializes in the severely mentally ill, including some of those hard to place patients, is a benefit of a freestanding psychiatric hospital that has separate units and can accommodate that separately. So that's one of the things that we've been asked to do and have agreed to do. And of course, we'll treat all psychiatric and substance abuse diagnoses, and we'll have partial hospital, which is day treatment, intensive outpatient, where people come a few times a week for a few hours. And the inpatient, the partial hospital, and the intensive outpatient make up what we call a continuum of care, a complete continuum of care. To the traditional outpatient, going to a therapist every week or 2 weeks and going to a doctor for meds, we leave that to the providers in the community and partner with them to provide that care when they're done with their treatment at our facility. And patients can come straight into outpatient and never need to be inpatient, and they can move from one level of care to another based on their need. And one of the things I have to agree with Dr. Cote on is the importance of the outpatient. Of course, we want everybody to be treated outpatient if they can be. And there's even, in Texas, years ago, we came out with this right called the right to the least restrictive environment. It was one of the most abused rights that I ever heard of, because it ended up getting used as an excuse to not give people inpatient or to fund inpatient, okay? And there are a lot of people who need inpatient that are very severely mentally ill, or who just maybe need it once in their lifetime, or who may need it many times in their lifetime. And if somebody, like Rita said, I'm glad she brought up the stigma, if somebody has diabetes and something goes awry and they get put in the hospital, we don't say, you failed at outpatient treatment. But in mental health, we use the term, you failed at outpatient treatment, okay? So what we believe in is the complete continuum of care, and that the level of care that the person is in, what's recommended, be a clinically based decision, and that neither is more important than the other, and that there's no shame in needing any of those levels of care when you need them, and that we want to provide all of them, okay, that are required. Next slide. The leadership team at US Health Fest has experience developing and operating psychiatric hospitals that meet the specific needs of the community. And like I said, that's our thing. We work together with the community to really identify the needs and determine where the highest needs exist, and then create those specialty programs to meet those needs. Next slide. This is our management team. We're a fairly new company, but our team's been together at a prior company, so we're a new company with an old team. And we realize that we're the new kids on the block. But we think that's a good thing because we think sometimes bringing in the new kids and having some fresh ideas and input and partnership is a good thing for the community. Dr. Richard Creigh is a psychiatrist, and he's the president and CEO of our company. And I'd like to introduce Neil Creigh, who is the chief operating officer of our company, who's sitting right back there in the room. Next slide. The needs in Prince William County, which is really what we're here to talk about. And my role in the company is human intelligence. There's a lot of people who are really good at doing like methodologies and data and things like that and figuring out how many beds per population and all that to decide if there's a need. But I come in and talk to real people, and that's what my role is, and that's what I've been doing for 24 years. And so the assessment is that the shortage of beds and the inequitable distribution of the existing beds in the planning district, and I'll explain what the planning district is, and the lack of specialized care in the planning district really ignores the behavioral health care needs of the residents, specifically of Prince William County. Next slide. You don't have to be able to read all that, and I use this slide just so you can look at the map. If you look on the bottom right, green, that's eastern Prince William County. That's where we would put the hospital. There's 0 psych beds in eastern Prince William County. In western Prince William County, we've got the 32 beds from Novant, which you could tell from their speech, they're doing some really great work. But that's all the beds that you have in Prince William County, and all of the rest of the beds in the planning district, which is what this is, are all up in the north. And many in Fairfax, but all up in the north. So all of the people that can't be put into Prince William have to either go into this northern part, or they have to leave the planning district completely and go to other areas to get care. Next slide. We'll skip that one. Rita already mentioned that 25% of the people that the CSB see go out of the area. Next slide. Next slide. This entire emergency department sees over 500 psychiatric cases that they transfer to other facilities, and 23% of those are sent outside of the area. Not in the northern part of the planning district, outside of the planning district. Next slide. Just wanted to point out, because we have a specialty in treating combat-related disorders for military, that you have 42,889 veterans in the greater Prince William area, including a couple of military installations with active duty service members that we plan to treat on a 15-bed unit. Next slide. The community has reported a significant unmet need for additional inpatient psychiatric beds in William County. Next slide. So we've talked to folks, and we've gotten over 100 letters of support, community service board support, there's a petition, the Sheriff's Association, we've got legislators that are supporting us, bipartisan, and I put special mention at the bottom because there were some folks working real hard, but we just received an enormous amount of support from the community telling us that there's a need, this human intelligence, for more beds. Next slide. And then I just say, why U.S. Health Fest? We're ready to build a hospital now. And the commissioner is going to make a decision on March 26th. And if that decision is a yes, we're in development for a psychiatric hospital. And so if you're supportive of the idea of having us come into the community, my cards are outside, so please stop and grab one, email me or call me. I'm available 24/7. And then there's a one-pager with some Prince William legislators. And so if you want to help, you can call a legislator, or you can sign a petition that's out there as well that Cynthia Dudley with the Trillium Center has put out there. Thank you so much for having me.
Okay? So do we have any committee members who have questions? Yes, ma'am.
Linda Silverstreet, this is,
I'm going to repeat the question. We don't have the whole mic.
the question is, Ms. York, I read in the paper that there was a possibility that the certificate of need would be denied because they didn't think we needed it here. How can this be? I mean, how can that decider feedback.
Okay, so I'm just going to repeat the question. Linda is asking about the certificate of need and the possibility of it being denied, and she's wanting an explanation of how can that be. So it was addressed to you if you would like to come up and answer on the mic. Yeah, unfortunately, you do have to come up so that it's on film.
The certificate of need process, like I said, has several stages. So there's a local regional board that first votes on it, and then it goes to the state. And it was denied at the local level on a lack of need. There's some methodologies, like I said, I'm not an expert on methodologies, but there's some differences of opinion on some methodologies in terms of how they're coming out on showing the need. And so we are arguing against that methodology being accurate or adequate to assess the need, because we feel like we've uncovered enough human intelligence and data to prove the need, and that we have asked the commissioner to set aside that methodology and to use the other criteria in the law to approve our application.
Unless I get in trouble.
The first question is, the other beds that are available in the planning district, what's the percentage of utilization today?
So the beds that are in the planning district, what are the percentage of utilization today?
Yeah, what's the percentage of utilization?
So who would like to answer that?
That's got to be one of the criteria that
What the hospitals are reporting is 70% is their occupancy rate, which is one of the reasons why they're saying there's room for, there's available room. But the problem with that is a couple of things. And one is that demand kind of peaks and goes up and down. So we're hitting some of those high demand periods where there are no beds, and that's why we're having to go outside of our region.
The problem is that the rest of us have to pay for that 30% of unutilized beds. Drives up the cost.
The other thing that occurs is that when you're dealing with psychiatric patients, they usually have 2 patients to a room. And if the one patient is too dangerous to have a roommate, that bed is shut down.
Second question. Electronic medical records, which is obviously famous. I have an electronic medical record from a hospital. Are these things patient-centric, or are they hospital or healthcare system-centric?
Okay, so the
In
question.
other words, if I have a record at Centara, and I go to somebody at Nova, does that all accumulate in a patient-centric record?
Okay, so the question is basically, when we have electronic records, are they portable, or by person, by patient, or do they stay with the hospitals?
I'm not an IT expert, but I'm going to tell you today, no. I can tell you Centara Healthcare as an enterprise has what's called Epic, okay? And
every hospital kind of has their own thing.
correct. And so
solve any problems.
correct, today. So again, F7 interfaces, the goal is eventually, and the expectation, and who knows how many years, that there will be a record, a single record nationally. Almost what they have for the VA today, where I can be seen in Boston and be seen in San Diego, and you can access my records. So if they can do it in the VA, they did that 20 years ago, why can't they do that in industry? But we're not there today because of that. So I would say today, it's not patient-centric, it's still, but eventually, I think that really is the goal of the healthcare, is to aggregate data and look at episodes of care, because we need to manage populations. And whether it's mental health, diabetes, cardiac, we need to better manage our patients to keep you healthy and hopefully at the height of your quality of life.
We're gonna let the doctor go, and then.
To specifically answer your question, we have the same system, Epic, but it was designed differently in the sense that the company, there's a little bias, of course, I'm talking about Novant Health. The company that runs Epic, and Epic is for large health systems, not small systems. And we have something called My Chart, which is where the patient can, make entries. The information is the property of the patient, but of course the hardware, or when the doctor puts it in the window or the hard drive, is of course the property of the hospital. So that's one issue. The second is that local physicians or care providers will have access to that as well. So essentially, you could get an e-visit, a copy of your e-visit. You can have access and schedule appointments. So they're being refined every year. And the most recent one, Epic, is the most refined in the country, as a matter of fact, that was designated by Epic.
Okay, just a follow-up question. Okay, if I go to a lot provider, and I go to a no provider.
Yes. You will give permission so that if you, for some reason, were in a Novant hospital in North Carolina, that information will go to your doctor up in Northern Virginia. We can take even one state away. And that system allows you, but you have to give permission, and that is allowed. So when...
Okay, I'm not sure I understand. Let me just clarify.
I gotta cut you off.
Okay, but there is no patient-centric
No, not at this time.
Can I just add something?
We can.
I think there is some confusion.
Roll the chat.
Yeah, your first question about occupancy rate. We're talking about private beds now, okay, not public beds. If you want to talk about occupancy rate for the public bed, we have our state facility, Northern Virginia Mental Health Institute up in Fairfax, 98%. Okay, very, very little room there most of the time. They were very good about patient management and getting people in.
All right, any other? Marla.
So is there, it's kind of two, I'm going to follow this lead, he broke the rules, so.
You're going to get me
So one
fired.
is there any interconnection between some of the people that we have here? Like we've heard that we're sending people as far away to Williamsburg for TDO, and then if granted with the CNO, that will accommodate with CON, yeah, 75 more beds. So will there be any, I don't know what the word is, but connection where people can have first rights? That's the first question.
So, Marla, what district are you in?
Woodbridge.
Okay, and so your question is there any interconnectivity between the systems?
Right, will
To
there
allow
be
for
if there
patients?
isn't already, yes.
And who would like to address that question?
Can you just clarify what you mean by first rights? I'm not sure what you mean by that.
Not necessarily so much first rights, but and just listening to the presentations and listening to, it sounds to me, and I'm ignorant about the whole scope of mental health, but it sounded like there are more resources that could potentially be available just between the panel by itself. When you think about us having to send people as far away to Williamsburg, and I mean, I know Centera is a different than emergency service division, but you have the wonderful foundation that's providing resources. If your CON is approved and the behavior center of Woodbridge is going into effect and can occupy 75 beds, well, is there some sort of system that would eliminate us having to send the existing people who need services, TDO services specifically, from going to Williamsburg or outside of the greater planning and keep them here at Woodbridge Behavioral Hospital?
Yes, and that's what the psychiatric intensive care unit is about.
Okay.
It'll accept patients on TDOs, and the purpose of it, and it's, the size of the unit we discussed with all 5 of the Northern Virginia CSBs on what was needed. And in fact, they approached us and asked us, would you please help us with our hard to place patients? So that whole unit is going to be operated with a very close partnership with the CSBs.
Good.
So they'll be providing that discharge outpatient piece, and we'll be doing the inpatient piece, and we'll be operating like one system for that population.
Okay.
Does that answer your
That
question?
does, and that's music to my ears.
Oh, I'm so
So that's
glad.
good. And then the other question I had is, and this is for any of the panel members, are there currently any preventative assessments or things that can be done to identify mental health issues at an early stage? Maybe that's what the Youth Tomorrow grants are doing, I don't.
So are there any
Early
early diagnosis things available?
Maybe let the doctor.
That's a little tricky because there's something called personalized medicine that's coming in. Many of you know that. For $3,000 with simple swab in your cheek, you can get a sort of picture as to what you may be at risk for. Just because, for example, if you have a certain kind of gene for dementia or Huntington's disease, it can tell you that you're at risk, 50% risk. Or, for example, if you have a certain medication and you have what are known as isoenzymes in the liver, and we call them genetic polymorphisms. And so it tells you that you should avoid this medicine because you could have risk. So there are some studies that are showing that. It's sort of tricky. I personally wouldn't want to know at 67 I'm going to assisted living with dementia.
Right.
Not assisted living right but I'm just saying it's that's why it's called personalized medicine. Many people choose to do that. And we're slowly doing that. The first thing in psychiatry, in fact, or mental health, is what's called, in 2004, the FDA approved something called the cytochrome athlete chip for liver enzymes for drug interactions. And now some of those tests are as inexpensive as $60 if you want to get them. I mean, $60 could be expensive for someone who's underinsured or no insurance. But you can do those tests and they will help you. They'll tell you that this medicine won't work. We're far away from that, but we're getting closer and closer. There are, for example, if you have a family history, a higher family history of diabetes, there's a chance that I can tell you there are risk calculators. Two parents having schizophrenia, then the risk for the offspring is 40%, and you can tell them, but it's a little tricky. It's very early in the game. But many interns, if you've gone to the intern's office, you already know. You get a profile. When you get a medicine, you get a profile. And that's slowly coming. That will be the future, even in mental health, because we're just targeting medicines by diagnosis. It really should be parts of the brain and what is wrong from a gene perspective. Even though there's environment and gene interaction, we can still have it. We can still make a difference.
Thank you.
I'm gonna go back here. No, yes, ma'am. Thank you.
I'm Carol Knob. I live in the Gainesville district. And Rita Romano had the photo of Senator Deeds, and which brought a lot of this crisis up to our attention. And one of the problems was that his son did not get to a facility for long enough. But one of the things that's happening right now is trying to decide what the law should be, and I wondered if you could clarify the difference between the emergency custody order and the temporary detention order, and just how that's working in Williamstown.
So we're looking for a clarification of the laws that currently exist on the books for the different types of detention.
The ECO stands for Emergency Custody Order. So Captain Miller could talk to you about that because it's his staff that often will take a person into custody. So they have first a 4-hour period of time, and then they can be given by the magistrate an extension of 2 hours if we're still trying to provide medical clearance for that person or locate a bed. So the legislation that's being considered now, there's a lot of bills out there, all the way from 2-hour extension to 24-hour period of time. Senator Deeds put in a bill for 24 hours. I think that because there were so many bills that were addressing changing that piece of legislation, they have consolidated some of those bills. And it'll be interesting to see what happens. It could be that they're going to go for another 4 hours. It could be that they're going to do it at 2-hour extensions. We don't know yet. The temporary detention order is after a person has been evaluated. Sometimes an ECO has occurred, sometimes not. Sometimes people come into the emergency room, they're not accompanied by a police officer, and the emergency room physician feels that the person does need to be in the hospital. And if the person it doesn't want to stay and they feel the risk is too high, that's when they'll call the Community Services Board, my staff, the emergency staff, we have 24-hour coverage, we'll come in and do an assessment. If we feel that the person does meet the criteria, and it is pretty stiff, and we try not to go that route because we would much rather have a person volunteer. So it's really the last resort. If we do feel that it is necessary because of safety issues, then we will request of the magistrate a temporary detention order. Now, right now, the law you can hold a person for 48 hours. So that's only 2 days, unless it ends on a weekend or a holiday. And then it can be extended until court can be in session again. And basically, hearings will take place at the hospital, not at the courthouse. The special justice, such attorney in our community, comes and presides over those hearings. So they're talking about 2 things in regards to the temporary detention order. One is to make it a minimum that once the person comes into the hospital, that a hearing cannot be held for at least 24 hours. Some of the hospitals in Virginia hold these hearings the same day the person comes in. That's what happened with Cho. Hours after he was admitted, he went into a hearing. That's still happening in many parts of the state. The other piece of that legislation is to extend the period of time to 72 hours. And here in Prince William, we like to try to keep people at least as long as we can to still be within the 48-hour limit. The whole idea there is if we can have the person in the hospital for at least 72 hours, we're hoping that that person is going to stabilize just a little bit more and again be in a position where they're thinking better and perhaps they will in fact be able to be discharged or will volunteer for treatment. So I think we're going to see that pass.
My question is to the panel where are you getting your funding? Is this a combination of public funding, private funding? How are you operating your programs that you're doing right now? Where are you getting your funding? Is part of it coming from the state, federal government? Especially those who don't have insurance. I know that's where the target of the problem is that some people don't have access to insurance to get the services that you all provide. Okay. So, with that said, where is the funding coming to support the programs that you all do?
Okay, so the question is, where is the funding coming to support your programs, whether it's private, public, federal government, local, grants? Who'd like to start?
We're all going to be different, so we'll have to all address. For private psychiatric hospitals, we'll contract with all the managed care companies and all of the government insurances, Medicare, Medicaid, those, and then we'll contract with the CSBs for the funding that they have. We call that safety net funding sort of in other states. And then we will admit any patient in an emergency basis, regardless of ability to pay, when all that has been said and done.
Are you receiving any state funding?
No, we have our own funding. We're privately owned, and so there will be no state funding needed for us to open our hospital. We have all the funding already.
We typically, again, because we don't have a behavioral health unit, admit. We do have patients who are admitted for other diagnoses and mental illness is secondary. So if they have no insurance, it is part of our mission as a not-for-profit. If they're seen in our ED, in our emergency department, and they're stabilized and they have no insurance, we will continue to treat them. It's part of our mission. If they have insurance, then we bill insurance. And if they are a Medicaid patient, then that comes obviously from Medicaid. So
I think that covers all of it.
What about if they're from?
And then, I'm sorry, the Potomac Health Foundation, I apologize. So they have done a wonderful job in seeing the need and the power of collaboration.
What about those who are coming from being incarcerated, who have raised up arms? I'm sorry. It's still part of the question, because you're still talking about treating someone with a mental health issue who may have been incarcerated because they committed some heinous crimes such as rape or something of that nature, drug addiction.
Okay, well, we'll ask the others, you don't have to go into that situation, so.
Can I finish my question?
We did, and I was supposed to take one.
Okay, I have a second part, okay? And that is, that is, the second portion of my question is this, is if you have someone who has been incarcerated for committing a crime, a heinous crime, out in the community, and they need some sort of behavior program to get themselves healed so they can become productive citizens in our society. I mean, this is a
Right.
serious issue.
So the question
is, in that case, where is the funding coming to support giving these people the treatment that they need? The reason why I asked this question is because several years ago, probably back in 2006.
Let me go ahead and let them answer the question. I know, but we're only supposed to take questions, not statements.
I'm sorry. There was a delegate Jeffrey Fredericks, who had actually recommended some serious slashing of the behavior program.
Okay, so the modification of your question is if they have needs and they're coming from the prison system, where is the money coming for that? Do we have a panelist that can answer that modification?
I thought that was answered.
Do you want me to answer your first question first?
I do not.
Pardon me?
Both.
Both, okay. So, again, of the budget for community services, some of it comes from local funding. So that one slide I showed you, 18 million comes from the general fund here. The rest comes from the state. Some money comes from federal government. We get, some patients have Medicaid. That's probably the biggest payer source in terms of insurances. And it's important to note that a lot of the services that the CSB offers for the seriously mentally ill are not covered by the commercial insurances. A person can have Blue Cross Blue Shield, and if they need what we call case management, because they need someone to do more than just, they need someone to help them address all of their needs, not just, their mental health needs. Commercial insurances don't cover that. Medicaid does. Medicaid will pay for the crisis stabilization program. They'll pay for mental health skill building services. They'll pay for psychosocial rehabilitation. They'll pay for all those services. So that's really one of the reasons why we would love to see Medicaid expanded. Okay, so in terms of people coming out of the prisons or jails, there really is not anything that's specially targeted to that population. If you look at our regional jail, we've got over 1,000 inmates there now. We have 2 mental health therapists in the jail and 1 psychiatrist that's there for about 4 hours a week.
They just see some
and basically they're doing a lot of assessing of people. They're not doing a whole lot of treatment.
But what happens when they're released?
And when they're released, then sometimes they come back to the CSB.
I just want to answer your first question this way. Basically, just like the community100.org, these two systems, Centera and Novant Health, are not for profit. Now, not for profit doesn't mean not for loss. But it's important to remember that the margins, that means the amount of money that not-for-profit hospitals make are like grocery store margins, 2 to 4%, very low margin. And increasingly, unfortunately, since the last economic downturn, 2007, we've seen 24% of self-pay. That means at least if you look at psychiatry in our unit, many will tell you 4% and all that in their data. It's simply not true. 25% of our patients that we take care of are self-pay. Okay, 10 to 15% in the ED, emergency department, is self-pay. So we have a mixture of self-pay, Medicaid. The next highest really is actually Medicare is becoming higher. In our hospital, it's 40% of our revenues are from Medicare. So you notice that in not-for-profit hospital, the goal is to treat the community. In for-profit systems, it's important to note that they are beholden to the shareholder. They do have to serve the community. And there is a fourfold difference in what's called free care. The community sets a standard. The state says 1.9% or 1.5% charity care. Most hospitals, not-for-profit, are anywhere from 4 to 4.9%. It's important to remember that. But both systems have to treat. It's a law. If you have a viable emergency room, regardless of your ability to pay, you have to treat it.
Thank you.
Okay, we have a little more time. Do we have someone in the back that had a question?
Yeah, my name is Michael Ragland, and the question I have is, I talked to a psychiatrist, and he told me that when he practiced, if uninsured patients were admitted, they have to state, according to law, that they will accept any person regardless of their ability to pay or not. But he's seen people that are admitted who don't have any insurance, and within 24 to 48 hours are shipped out someplace else because they don't have any insurance. And she just mentioned to me, Romano, that the public psychiatric facilities have something like a 98% occupancy rate, and there is only one state mental hospital in the whole Northern Virginia area, and that's by the Virginia Mental Health Institute. So I'm wondering what the charity commitment, and again, this is meaningless because, you know, I don't think that a private psychiatric hospital is going to really treat that many patients seriously mentally ill that don't have any insurance. But having said that, I was wondering what the charity commitment will be of U.S. Health Vest. And to me, this is all money-making business. I'm somebody that suffers from illness, and all this food and drink and all these questions, just, you know, I mean, a lot of it makes me want to puke when I consider how people are suffering.
So your
right
question
now.
is that if people are uninsured,
Right.
are they going to get different treatment or none at all because they are uninsured? And what is the percentage commitment of charitable acts that they'll be doing for people without insurance?
Right, ma'am. I appreciate
Essentially?
that.
Okay. Can we get anybody to answer that? I think so.
Yes, there's laws called EMTALA laws that do require us to accept all patients regardless of the ability to pay. And historically as a company, we have just found that if we take all the insurances and we contract with the state for the seriously mentally ill, that those patients that are left that come to us that need care, it's manageable. It just is a manageable number. It's out of my area of expertise on the percentage, but I know that we did agree to, in the state, when we went to the state for our hearing, for all of the facilities there were that were asking for more beds, we agreed to the highest level of charity care of anyone in the room. Let me see, there was another part of your question I think I'm forgetting. Oh,
Yeah.
whether they get the same care.
Yeah, and I'm wondering, is the problem that there's a lack of psychiatric bed space, or is the problem that they're not able to admit somebody that has no insurance?
No, I can, and one of the ways I can answer that is that the state hospital, the Northern Virginia Mental Health Institute, the administrator specifically told me, and I've looked at the statistics on it, like 23% of the patients that were admitted there in 2013 have insurance, okay? Now, the reason that's a significant statistic is because to get in the state hospital with insurance, the referring clinician has to call 8 different facilities that turn them down before the Northern Virginia Mental Health Institute will accept the patient. So you've got almost a quarter of the patients in your local state hospital that should be being treated in the private facilities, it's not related to uninsured at all. And so they really like to have those beds for the truly uninsured and also for many forensic patients. And so that's why they're in support of our facility. You've got 30 patients in Western State Hospital from your planning district who are forensic patients that can't get in Northern Virginia Mental Health Institute, can't stay there because of all the private insured patients there. So there's a lot of patients displaced who are insured.
Thank you. Got a question right up front here.
Jack preemption, I'll share this with you. Michael Ragland wrote an excellent editorial letter to the editor, which I found exceptionally interesting. And I was just, what this tells me is that, and the question came up, the lady asked about partnering together. I think that's really critical to know as we look at the system-wide services, if there would be communication among all the parties to team together in a fashion, so the services would, those commitments are there, the community services board forms a vital function in the middle of all of this too, but teaming together is so important to the community that that's what we want to know is how will that really work? Will you actually get together, come up with strategic planning to make that happen as a reality?
So Jack, your question's that will these groups be able to work together and
will they commit to work together in a fashion to make that happen? Because the questions coming up all lean that way. The system-wide, if we can have those assurances, I think, then the public can breathe a little bit of a sigh of relief. And that's the question I'm asking.
so how do we play well together? Who would like to take that?
I'll give you a kiss.
We've been developing public-private partnerships for years.
Yes.
So again, the state will give the CSB money, and we in turn are paying for care in the private hospitals. So a lot of the people that we're referring to Novant Health now and their psychiatric unit is paid for with what we call LIPOS funding. And again, the TDOs, that's paid for by the state. So regardless of whether a person has insurance or not, there's money that comes along with that. And so again, we're using the private beds, not our public beds. We're trying to go to the private beds first, and only if we can't get a bed there are we going to the institute. So we meet frequently. There's a meeting that we hold over at Novant Health. It generally is all the parties involved in the involuntary commitment process. So we've got all the 3 different police departments there. We've got the sheriff's department. We have Novant Health. We have people from the ED. We have people from the psych unit. We have people from Dominion Hospital, which is a freestanding hospital in Fairfax. We have somebody there from the Innovas. We have somebody there from Northern Virginia Mental Health Institute. And the whole idea is to try to focus on coordinating well together, playing well together, having good relationships, so that it'll benefit the individual who's being treated and trying to get through this process. So yes, we have been nurturing those relationships, and it's vital, absolutely vital.
But getting that message out seems to be what we need to do.
What district was Mr. Ragland from? I didn't hear.
I didn't either. What district?
I'm from Dumfries District.
Dumfries. Yes.
Jim Amaral, Neabsco District. We've heard a lot about severe mentally ill people, but we have a good number of people within the community who are moderately mentally ill. Their families may not, you know what it is, families may not be taken to an emergency room to have them treated, but they know some treatment is available and also funding may be limited. What services are available within the community to help those people?
Okay, so if I understand your question, if you have a family member that has a functioning, they're high functioning, but they have a problem or an issue, what resources do they have in our community available to them, especially if they don't necessarily have the funding or the insurance?
Correct.
Okay.
First of all, I named a couple of them, I highlighted a couple of them that were funded by the Potomac Health Foundation. And so, for example, 2 of the projects that were funded
would be Youth for Tomorrow. So obviously these are pediatrics, so that would be an example, and that's for behavioral health, disruption, anger management. So the kids have to be assessed by one of their intake specialists, and based on their presentation, they will either be included as part of that project or else be referred elsewhere. That would be an example. I talked about another program called The Active. That's more for family dynamics. So again, if there is a parent who has anger management, behavioral health, alcoholism, that is another program that's funded by Potomac Health Foundation, which is a collaborative of folks in the community that not only train the clinical staff in 3 different services, but then also serve the community, and that's just the family piece. Then obviously you've got, those are free and they're funded by the foundation. Then you've got, you know, some of the psychiatrists and the licensed social workers and the psychologists. But what we're finding in this market is that they're, all of them seem to want to go north into the district and maybe Fairfax and whatnot. So there is a undersupply. We have a need. So one of the things that we really want to do as part of our community health needs assessment, the power is in the coalition. The power is in working with, and I talked a little bit about a couple of the coalitions that we're looking at, is working with the school systems, knowing that cyberbullying is real, knowing that how do we use telemedicine to help augment the school nurses with a child who is disruptive or threatening that he's come in with a gun or a bomb. Actually, I met with Teresa Polk yesterday. We were talking precisely about that. How do we use telemedicine, MD Live, to help at least stabilize initially, as an example? How do we look at a mobile crisis van, where we always expect people to come to us? We need to start thinking differently about, we need to take our services out to the community. So not unlike what we do with our mobile health van with Evelyn Marr, New York, actually about half the states in the country have these mobile, again, truly it's a van, mobile crisis teams. And they sometimes sit and actually treat appointments at a CSB. Or again, if they get a call, a 911 call, that not unlike an ambulance, that mobile van is deployed to that household or to wherever the issue is. So I don't know if that answered your question, but there are programs through the Health Foundation, and then there are private providers out in the community, although there are not a lot of them. So the last piece of it is we need a workforce development issue. So working with George Mason, they have a medical campus in Prince William. They have a great nursing program up in Fairfax. Walden, which is an online, as part of our community health, we had one of the nurse practitioners from the National Coalition of 100 Black Women. She is a nurse practitioner who's a professor at Walden University. We need a pipeline strategy. We need people who are passionate about mental health and who want to get into that line of work, because that actually, I think, is one of our biggest opportunities as a collective. And how do we think a little bit more strategically in the training and the deployment through, again, whether it's telemedicine or telepsych consults.
So to answer your question, sir, basically what we recommend is 70, if you look at someone who needs medication before counseling, let's just say, 70% of prescriptions for psychiatric medicines are written by primary care doctors. Most people prefer the comfort and Senator Barker, with the help of federal funding, has gotten a mid-county office where he sees all kinds of patients. They take insurance and also walk-ins are welcome. There are walk-ins and they're opening a new facility, a brand new, I think, $349 million facility off Liberia, the sort of western part of the country. Yes, Prince William Health Center in the western part of the county. And there are a lot of providers and they seek our assistance for consultation for mental health. So you have people who have no insurance who can go there. Then you have, there are always people who come to the ED. But I think if you look at the country in terms of trusting people, a nurse, doctor, and pharmacist in that order. So even the triage nurse at the primary care, the patients are confident. They really feel comfortable talking to them. And that's the way to go. And psychiatry, the problem is 50% of psychiatrists in this country are over 55. And many of them are leaving the mental health field because of all the regulations and things like that. That's why we need more practitioners. And thank you.
Okay, we are going to have to wrap up, so appreciate all the questions. Want to give a quick plug for the committee. If you want to join, again, it's only $30 a year. So, plus a free holiday party. You can't beat that. That's a deal. So I'm going to hand it back so that Denny can do closing remarks, and I want to thank you all for coming out.
Thank you.